So good evening, everyone. I, Dr. Aarti Heda, welcomes you all on behalf of team
Wait,
surfing
wait,
the anterior segment.
wait. We aren't live yet.
It shows meeting is now streaming live.
Aarti, go ahead.
Good evening, everyone. I, Dr. Aarti Heda, welcomes you all on behalf of team surfing the anterior segment to the session 10th. With the goal of providing a direction to the professional careers of next generation, Yossi has become the voice of young ophthalmologists. Surfing the Anterior segment is a case and a video based webinar series initiated by UC, wherein we aim to discuss and understand the complexities of managing an ophthalmic case and providing a fresh perspective to the approach. So, without further delay, let's start today's session. So, let me introduce you, my co moderator, Dr. Nandini Chandak. Dr. Nandini has done her cataract and refractive fellowship from BBI Foundation, Calcutta, and she is currently working as a consultant in various hospitals in Calcutta, including BBI Hospital. Over to you, Nandini.
That was a real nice introduction. Thank you. So we'll start with our session for today. Our panelists, can I share my screen, please?
You can.
So we have a group. We have the first panelist as Dr. D'Souza, who is a consultant in the Department of Cornea and Refractive Services and also the coordinator of Ocular Surface Clinic at Narayana Nethralaya. She has completed her medical education as well as her post-graduation from St. John's Medical College in Bangalore. She did her fellowship in cornea and refractive from Narayana Nethralaya and also did an observership at Singapore National Eye Center. She has keen interest in ocular surface related conditions, keratoconus and refractive surgeries. She is currently doing a PhD on the ocular surface immunology and immune cell profiling from the University of Maastricht. So we welcome you, ma'am. It's really nice to have you with us.
Thank you so much. My pleasure.
Our next panelist today is Dr. Ridhima. She is the director of Pioneer Medilaser Private Limited and also of Nayanjot Eye Clinic. She has done her long-term fellowship in anterior segment and trauma from King George Hospital in London, and also done her long-term fellowship in phaco and refractive from Narayana Nethralaya. She's completed her MS and MBBS from BJ Medical College. It's really nice to have you, ma'am, on board with us today.
Thank you very much. I'm very happy to be here.
Our next panelist today is Dr. Samresh Srivastava, who is a consultant ophthalmologist at Raghudeep Eye Hospital, Jaipur and Ahmedabad in India. He's done his DMB from Shankar Nethralaya, Chennai, and the fellowship from Raghudeep Eye Hospital, Ahmedabad. He has special interest in management of cataract and refractive surgery and has keen inclination to understand and research of all eye disorders, particularly optics of the eye. He's been the invited speaker and panelist for a lot of international and national meetings. Welcome, Dr. Samresh.
Thank you. Thanks a lot.
And coming to the speaker for today, Dr. Gunjan, who is one of our core team members as well. She's currently pursuing her long-term fellowship in cornea, refractive and anterior segment at Shroff Charity Eye Hospital. She has completed her DNB from Venu Eye Institute and pursued cataract fellowship from Shroff Charity Eye Hospital. She has worked as a consultant in phaco refractive services at Vistec Synergy Eye Center. She has special interest in refractive surgeries, cornea disorders, and endothelial keratoplasty. Over to you, Gunjan, for the case presentation.
Thank you. Can my screen be shared?
So So let me just remind our audience, if you have any questions, you can put up in the chat box. We will take the questions after case presentation.
Is my screen visible?
Yes.
Okay. So should I start now?
Yes.
Good evening, one and all. Today I'm discussing cases of refractive surgery with the esteemed panel. So the first case that I'm discussing is of a 23-year-old female who's a student by profession. She has a history of using glasses since 12 years. She came to our clinic and she had the request that she wanted independence from the spectacles. There was no history of any systemic illness, no history of any ocular surgery, and there was no history of contact lens use in the past. There was no family history of any cataract disorders. On further examination, the visual acuity in right eye uncorrected was 20 by 400 and best corrected with glasses was 20 by 20. The spectacles that she was using in the right eye was minus 15 diopter spherical with a cylinder of minus 3.5 diopter at 30 degrees. In the left eye, she had a spectacle power of minus 7.5 diopter spherical with a cylinder of minus 2.5 diopter cylinder at 170. So we performed retinoscopy under dilatation as well, and we confirmed it as acceptance. So the acceptance was minus 15 diopter spherical in the right eye and minus 3.5 diopter cylinder in the right eye. In the left eye, it was minus 7.5 diopter spherical and minus 2.5 diopter cylinder. The IOP was normal in both the eyes. On ocular examination, the anterior segment findings were unremarkable in both of the eyes, and the fundus also was within normal limits. On periphery examination by the retina clinic, there was no treatable lesions that were found in both the eyes. So at this point, we also performed dry eye workup, topography, and we also checked for the dominance pattern of both the eyes. So on the topography, that is the pentagram that we performed, we found that in the left eye, the K1, K2 values was 45.4 and 48.4 diopter. That is a very steep cornea. And the pachymetry was 533 microns and anterior chamber depth of 2.96 mm. On Bellin-Ambrosio chart, we can see that there is no ectasia that is noted, and the line is also not dipping before the 4 mm. So we consider that there is no red flag sign in this eye, considering that there was a high cylinder. In the right eye, we can see that K1, K2 values were 45.3 and the K2 value was 46.4 and the pachymetry was 529 microns and the anterior chamber depth was 3.19 mm. Also, we performed a scan for this patient to note the white to white. In the right eye, it was 11.5 mm and in the left eye, 11.4 mm. We also confirmed with AS OCT in this patient. So at this point of time, we had different options that were there. So in the right eye, as we see, she's a 23-year-old female with a refraction of minus 15 diopter spherical with minus 3.5 diopter cylinder and the stable refraction for 1 year. The pentagram had no red flag signs. The thinnest Pachy was 533 microns. But we also know that we have to have a residual bed of at least 250 microns to perform any LASIK procedure. So we have various options at this stage. First option is definitely that we can refuse the refractive surgery to the patient, or we suggest that the patient should use contact lenses, or again we have this option of giving ICL or IPCL, but we have to consider the economic consideration as well, and any other clear lens extraction or smile procedure as well. In the left eye, we have a refraction of minus 7.5 diopter spherical and minus 2.5 diopter cylinder. And pentagram had no red flag signs. Thinnest Pachy was 529 microns. So we decide that we can go for a right eye toric IPCL as there was a high cylinder as well. And in the left eye, as we can see that there was adequate pachymetry, so we can plan for a LASIK in this patient. So we went ahead in the left eye first, and we gave her a femtolesic option, and then she had a good result in the post-operative period. In the other eye, we went ahead with the toric ICL, and this is the sheet that is showing the ICL parameters. During the surgery, there were no complications noted. On the postoperative results on the first day, the right eye uncorrected visual acuity was 20 by 20 parts, and it was IPSL was stable, and AT was 14 mm Hg. The fundus was normal and retina was on. The AC was also well formed. In the left eye, uncorrected visual acuity was 20 by 20 parts. The flaps were in situ, and the interface was clear. So this patient has been following up with us also. We suggested the post-operative care as in the right eye. There was a standard post-operative care regimen. Eye drops prednisolone 4321 in tapering doses was advised, and antibiotic eye drop for 1 week was also advised. In the left eye, again, we had a standard post-operative care regimen, and then we went for fluoromethalone 0.1% in tapering doses. We also gave her lubricating eye drops to be used as and when she can put in the eye. She has been following up for over 1 year, and she's maintaining a good vision in both the eyes. Her IPCL is stable, and AT is 16 mm, AC is deep, the lens is clear, and fundus and retina is stable. In the left eye, she has 6x6 vision, flaps are in situ, and interface is clear, and pentacam is also stable. So moving on to the next case, which is almost similar to this case that I have presented, is of a 26-year-old male who's a college student. He has a history of wearing glasses since 15 years, and he told that there was the last change of glasses 1 year back. There was no history of any ocular surgery, no history of any systemic illness, or any other family history of eclectic disorders. Visual acuity in right eye uncorrected was 20 by 400, and in left eye 20 by 200. And he was wearing glasses of -7 diopter spherical in right eye with -0.5 diopter cylinder. In the left eye, -13 diopter spherical with -1 diopter cylinder. The acceptance in the right eye was -7.5 diopter spherical, and in the left eye, -14 diopter spherical. The IOP was normal in both the eyes. The ocular examination, anterior segment was normal in both the eyes, and fundus was also within the normal limits. There were no treatable lesions that were found. On pentacam evaluation in the right eye, the K1, K2 values was 45.4 and K2 was 46.2 diopters. And the pachymetry was 524 microns with anterior chamber depth of 3.3. I'm sorry for the black and white images because this file is from 2 years back where we did not have EMR. So we had a scanned copy. So I am using those scanned copies here. Then we went ahead and saw that in the Bellin Ambrosio also there were no red flag signs that were noted. In the left eye, K1, K2 was 45.4 and 46.5, and the pachymetry was 550 microns in this eye. Anterior chamber depth of 3.34. So again on the Bellin Ambrosio, there was no red flag sign that was noted. So on the A scan, we can find wide to wide diameter in right eye was 11.7 and left eye was 11.8 mm. So at this point, again, we had similar options, whether we refused the patient for a left eye refractive surgery and went ahead and go ahead only with LASIK in the right, or we give him an option of hybrid option, that is right eye plan for LASIK and left eye IPCL after the YAC PI. So we went ahead with eye LASIK first in the eye, and then in the left eye, IPCL was performed with a power of -14 diopter, and we did this IPCL after 2 weeks of YAC PI in the patient. The post-operative results in the right eye was within normal limits, and the visual acuity uncorrected was 6 by 6 parts. In the left eye as well, IPCL was stable and AC was well formed. So here I want to ask the panel a few questions that came up in my mind while I was making these cases. Whether you decide for bilateral ICL or hybrid option also is preferred nowadays, because in our institute sometimes we prefer to go for ICL. So do you recommend ICL for low myopic patients as well, or do you still want to go for a smile or a LASIK in other eye, and the eye that we cannot do the LASIK procedure, so do we do ICL in that? Do you prefer to do PI in every case? Because nowadays we have advanced ICLs with central hole. So in the literature also they say that the advanced ICLs, they do not require PI in each of the case. And what are your preferences? If in case ICL is not possible, do you suggest to go for a clear lens extraction? Fourth question is, do you suggest multifocals in young patients? Since we have good options also, multifocal or either panoptics, or I mean trifocals, do you suggest those options also nowadays? So that is my question for all the panel. So there, I want to ask opinions from all the experts. Thank you.
Thank you, Gunjan, for the lovely presentation. So let's take up these questions first, Nandini. So if Dr. Ridhima, you can take the first question.
Yes, hi, thank you. Thank you very much, Gunjan, for your nice cases. So the first question is, would I prefer doing a bilateral ICL, or is it okay to proceed with a hybrid procedure? So just like both the cases that you presented, if one eye has a 6 or 7 diopter myopia and with a good corneal thickness, I do not mind going ahead with a hybrid procedure like a smile or a femto LASIK in one eye and an ICL in the other should be okay. Like I've done it in quite a few patients. But if it is dicey, there's not that much, the difference in the refractive errors is not too high, then probably I would ask the patient to proceed with a bilateral ICL option if one is not fit. But the cases that you presented, probably I would do something similar to what you did. And do I prefer a PI in every case? Not really. I usually opt for phakic IOLs that have central holes, and I would try and avoid doing an iridotomy or iridectomy. So even if I go ahead with an IPCL, the version 2 has a central hole. The only situation where there is no central hole, if it's like a hyperopic ICL, which is extremely rare, but then I would prefer doing a surgical iridectomy at the time of the procedure rather than a laser one. Yeah. I will give my preference if an ICL is not possible. I will not push for a clear lens procedure in a young myopic patient. I will not prefer going in for a multifocal. Usually myopes have adequate anterior chamber depth to proceed with ICLs. In most cases, it is possible if a laser procedure is not possible. But if an ICL is not possible because of, corneal endothelial issues, or the lenses and, the zonules are not probably strong, or there's an early cataract. If there's other comorbidity, I think that has to be individualized. But only in I think a hyperopic situation would I think of a lens procedure, not in a myopic patient so early on. Thank you.
Yeah, so I agree. Yeah. Right. So I agree with what Ritima was saying. We've done a lot of hybrid procedures as well. And most of the times patients are quite comfortable. Of course, they have exactly the same apprehension that is being discussed here as to how they'll feel post it, because they know that the procedures are so different. But actually, most of them don't really face any problems with their binocularity or the depth post-operatively. So the same concerns, if it's such a stark difference between the two eyes, then of course what you did was perfectly right. You can do this option. If it's very close, as Dr. Ridhima was saying, again, you're concerned about the same things of RSB or how much tissue you're ablating. So the same criteria go through. The only thing is, if an ICL were not possible for whatever reasons, then the last option, which we didn't really take into consideration, is to offer them, to give them an option of an undercorrection in the eye. Of course, not if you're leaving behind 6 or 7 diopters, of course, but if it's a smaller, 2-3 diopters, they're sometimes willing for that if you feel that it's the safer procedure. So even that is fine to, explain to them and give them that, because you'll have corrected one eye fully, so they could manage most of their tasks. So even that is a good option for many. Of course, not if you're leaving behind a very large refractive error.
So I think, first of all, Gunjan, that was a very well presented case, very detailed presentation. There are a few points for the first case that I wanted to discuss. One thing that goes a long way, I think the choices you made were right, and both Ridhima and Sharon have said the same thing. But I think it all boils down at the end of the day to counseling, because there's a big patient factor in this, because you're going to be operating both the eyes separately. And what patients tend to do often is go home and keep doing this and seeing. So we have to tell them that it's a binocular procedure. And if you compare, obviously you realize that, the ICL will give you a better vision quality as compared to a LASIK, even with the discrepancy there is in this situation. So you have to tell them. Then, ICL, for me, the first choice would be to do a bilateral ICL, because the optics would be the same, purely from vision point of view. And second, if at all I am planning a LASIK, I would tell the patient that you will always appreciate a difference in quality, because your Ks are going to be significantly flatter in the low myop eye compared to the ICL eye, because you're removing a tissue there. So that's one. The second important thing to understand is, I think one thing that should be brought about is, with the Ks like that, 48 Ks and all, it's always better to go ahead with the laser-based procedure, like a femtosecond LASIK, rather than doing a microkeratome, because chances of flap complications may be slightly higher. That's something, that's a very subtle point to understand, because all of us have suffered it at once or twice, and it's not a good feeling to have, especially for young who are starting their practices. LASIK complications are probably the worst if they happen. So it's always good to keep that in mind when we're doing it. Most importantly, my preference for is to never, if at all possible, go ahead with the lens exchange for a myope, because you're removing a thick lens and you're putting a thin IOL, and you're giving that much more space for the vitreous to donis. So a patient that does not have a treatable lesion now can safely, in few years, go ahead. And, the most common cause of retinal detachment is pseudophakia. So you don't want to go ahead and do a pseudophakia and a high myope so early on. The problem is in their eye, and, it's not up to us we're not committed to give them 100% vision all the time. So I think it's best we counsel them. We know the competition will go ahead and do a lens exchange, and we've all had patients like that. But in the long term, everybody will appreciate the fact that you give them the right advice, if not initially. So no lens exchange as far as possible for a high myope.
Right. To continue this, and since we have such an esteemed panelist, I would like to ask, if we are going for a hybrid procedure, what is your choice? First LASIK, then ICL, or first ICL and then LASIK? That's one. Second, what should be the gap between the two procedures?
Thank you, Dr. Nandini. I think that since we are doing a refractive procedure, there doesn't need to be a very large gap between the two eyes. I have also done it on the same day, but usually it can be like as short as a couple of days or a week apart, and that should also be fine. Because we're doing a refractive surgery, I mean, the patient would be happier once both eyes are done. In terms of preference, which one earlier and which one later, I think one is an intraocular procedure. I usually do the ICL first for just my preference, and follow it up with a corneal laser procedure. But I've also done both on the same day many times. And then the order is same usually, the ICL followed by the laser.
Thank you, ma'am. Dr. D'Souza, can we know your experience for this year?
Yes. So I think the point which Dr. Samresh had brought about binocularity is very important and relevant to this point that you are bringing up. So because we're trying to give them, good depth, and that binocularity is what we're trying to achieve. So you can't keep too long a gap, maybe a couple of days or a week at max. And patients are also eager because they have to take leave, they have to arrange, their schedule accordingly. So they also prefer to have it close. In terms of which one first, I don't think it matters too much because I would usually do the LASIK. That's just, again, purely convenience, but I don't think it matters at all. So whatever works for the patient. And I've never done on the same day, but I guess.
I think this is a trick question, because there's no clear-cut answer.
There's no clear answer to this. Yes, absolutely.
So my preference would be to do the weaker eye first. I always tend to touch the weaker eye first. I tell the patient, this is your weak eye. More importantly, for me, being a primary cataract surgeon, I can gauge the patient's behavioral patterns with an intraocular surgery better than with a LASIK. So I'm more prepared, to handle the patient post-operatively after an ICL and prime them up for LASIK. So I would tend to do a lens-based procedure first. But that's again, because I am a primary cataract surgeon, that's probably why.
Right. And the other question, just hypothetically, if we were doing ICL for both the eyes in the first case, what would be the gap in the thing? And also, if we were doing LASIK, what is the chances of regression in that case?
Okay, should I go first? Okay, Samresh, yes, please go ahead.
No, I just wanted to understand, in terms of ICL, my gap, I normally keep a gap of 1 week between both the eyes. And when I'm doing an ICL, I would always do the worse eye first, because I want to touch the better eye after the first eye settled. Sometimes patients take a little longer. Sometimes the ICL is a little shallow to start with and it slowly settles down. So I keep that time gap in mind. I tell the patient that anywhere between 1 week to 2 weeks is when I'm going to touch you based on the first eye response and the IOP settling in and the inflammation, which fortunately does not happen with the ICL, and I'd have a very limited experience with IPCL. In terms of LASIK regression, I would only touch the patient's eye when I'm sure there's going to be no regression happening. So when the general cutoff is 250 microns. In my clinic, I keep the cutoff between 280 and 300 microns.
300.
And 300 is this thing. If it's going 290, I will say no to the patient, because I've had a few bad experiences in life for the long years, and I think one has to decide your own cutoff. So not to push the limits with LASIK, I think it's best to play conservative.
Yeah, I agree in terms of the cutoff. So I don't think once you're at that very higher limit, it's not even a borderline anymore in the second eye. It's way beyond what we can correct safely. And even though many of these cutoffs and percentages have been given based on lab analysis or mathematical calculations, but still we go by it for a reason. So medical legally also you'd be in trouble if this patient, not all of them develop problems. We know from years of seeing people coming back with very high refractive errors which have been corrected everywhere. But yeah, now in with newer experience and knowledge, it's better not to touch like the -13 and -15 diopters of refractive error with a LASIK, or even a SMILE for that matter. So the smaller thing, it doesn't. So there, the problem is not the regression. Probably you'd be more concerned about them developing an ectasia. Of course, we do know that the higher powers can of course have a higher risk of regression. That's because they may have a pathological myopia there. That is there, but the problem would more be to ectasia.
Right. So taking the discussion forward, we have a question from our audience. Dr. Prashant wants to know, what are the problems does one face in hybrid options?
The problems are patient keeps comparing the two eyes, just like Dr. Samresh had mentioned initially. Like in the ICL eye, they may notice halos initially, which they may not notice with the SMILE eye or with the LASIK eye. So the comparing of the experience between the two eyes about which eye feels more comfortable and the photic phenomena, I think other than that issue, I think both procedures have a quick and rapid recovery. And in terms of their efficacy, stability, I don't think they're going to have much difference.
So are there any studies done on this, like patient satisfaction level after a hybrid procedure and let's say bilateral ICL or bilateral LASIK? If any of the panelists have come across?
So we actually studied the IPCL and we looked at the optical quality of IPCLs. And, at the end of the day, for a person with a myopia of that diopter, the visual quality is always going to be good. It's the low myopes that will bother you. So, or the lower powers. The number like that is without glasses is probably almost as good as, blind. And such a patient will always appreciate good quality. So they tend to overlook a lot of these things that you might find on, practical eye trace evaluation or an aberrometry evaluation. You can find whatever bizarre stuff you can find, but the patients are generally very, very happy simply because you got rid of such a high number. And, the patient is generally very, very happy simply because you got rid of such a high number. And, the patient is generally very, very happy simply because you got rid of such a high number. And, the patient is generally very, very happy simply because you got rid of such a high number. And, the patient is generally very, very happy simply because you got rid of such a high number. And, the patient is generally very, very happy simply because you got rid of such a high number. And, the patient is generally very, very happy simply because you got rid of such a high number. And, the patient is generally very, very happy simply because you got rid of such a high number. And, the patient is generally very, very happy simply because you got rid of such a high number. And, the patient is generally very, very happy simply because you got rid of such a high number. And, the patient is generally very, very happy simply because you got rid of such a high number. And, the patient is generally very, very happy simply because you got rid of such a high num So if you look at it practically, I don't see too many unhappy patients in the clinic for myopes like that. If you look at it scientifically, you can find all aberrations lying around because of the optics that have been put in the eye, but it doesn't translate into a clinical value to me at all. But like I said, my cutoff for ICLs now has dropped, has gone down significantly. So I'm doing more. Anybody with a refractive correction of more than 8 diopters, my primary preference, even with the good RSB, would be to go ahead with an ICL as the primary counseling tool. And if finances don't permit, or there are the white to white small or the ACD shallow, then I tend to err towards a femtosecond procedure. But beyond 8.5 diopters of refractive correction, I tend to counsel patients for an ICL first.
Right. So we have a question from Dr. Krishna. He wants to know any experience operating on people who understand indirectly and eventually developed cataract.
We lost you there. Can you repeat the question once?
So any experience operating on people who understand hybrid procedure and eventually has developed cataract? So if I think he wants to find out if the ICLI has developed cataract. So what is, does anybody have any experience with this? If Dr. Krishna is there, he can put up his question again.
I got the question. He wants to know if a patient who's undergone a hybrid procedure, if we have seen such a patient develop a cataract, and then, what's the risk of such a patient developing a cataract, like which eye would develop it early probably. And okay.
Okay, fine. So maybe you can comment on that, Dr. Vidubha.
So I haven't had such a patient. Like I've had cataract in an ICL patient and cataract in a LASIK patient in different patients, not in the same patient. But I do not think that with the ICLs that we have now, that the risk of developing a cataract is going to be earlier in that eye as compared to the other eye. I think they would be developing like age-related cataracts at a similar stage, and the approach would not be that if we need to discuss how we would calculate the IOL power in such cases, I think that's a very long discussion, but I do not think it would be very different in a patient with a hybrid procedure as compared to one, with just either an ICL or a LASIK procedure. I think the outcomes would be similar.
Yeah. Also, I think important to understand different perspective to look at the same question is you're doing an ICL for the patient because you can do nothing else, quite frankly speaking. So it's very important when you counsel the patient to put it in their ears about glaucoma and cataract building up in ICLs because it is a potential possibility. And you tell them this is the best there is in the industry and in the healthcare system right now. And you may develop a cataract. You can put it in their ear and you can subtly draw it out so that the information is being passed on, and so this does not come as news to the patient if it happens. Thank God it's not happened to, I hope none of the panelists here, but even if it does, I counsel 100% of my ICL patients for cataract development, but I do it in a way that it just enters their ear and it comes out and it doesn't register in their minds, so I think that's something one has to do.
So I have seen cataracts, but with the earlier version of ICLs that didn't have the central holes, and they were typically very subtle anterior subcapsular cataracts that were not even visually significant. They were not progressive. We observed them for a couple of years. So after the phakic IOLs with the central holes have come about, I've not had any patient. I've not observed any patient with developing a cataract because of the ICL.
But yes, the point about, as you say, any of these complications are known things which have been reported. It's a good idea as we counsel for any of our procedures, whether it's a transplant or whether it's a LASIK, you go ahead and at least very briefly mention these things through. So it's not a completely unheard of complication to them. Okay. And another thing is if it's mentioned, make sure it's mentioned in your consents and that consent is given to them in advance with adequate time to read it so that, it's out there. So that's very important.
So we understand that counseling plays a very important role in when we talk, for that matter, any patient, but yeah, especially in a refractive surgery patient. So coming back to basics, let's discuss a few points about the workup. So I would like to know which cases do you do cyclorefraction? Is it done for all the patients, or are we okay doing refraction with tropicamide? And in the same line, where will you do atropinization? In which patients will you do that? So any of the panelists can take these questions.
So tropicamide is also a cycloplegic, though a mild one.
Yeah, mild one. Yes.
Yeah. So I
So
think
cyclopentolate. Okay, fine. So
Yeah,
cyclopentolate. Let me be
so
specific.
usually, the aim of cyclorefraction is that the accommodation of the patient does not interfere with our results of refractive surgery. So I think cyclopentolate I would use in hyperopes to uncover any latent hyperopia like before the procedure. But usually I would not mind doing a refraction under the effect of tropicamide in our regular myopic patients before the procedure. And I do not think I use atropine at all for any of the patients at the time of refraction. But I would like to know the views of the other panelists as well.
No, I agree. For most of our patients, tropicamide is the medication which we use. It's fairly adequate. Hyperopes are probably the only situation where I go for a cyclodilatation to make sure that we have the correct refraction. And not for refractive surgery, never had to use atropine. Relegated to children's refractions, I think. So otherwise, nothing.
I agree with Sharon completely. I think there's one or two places where we've burnt our fingers. I had a patient who's advised surgery elsewhere, came with a refraction printed on his hand and was showing a different refraction, myope again. And that's where we probably cyclopleased the patient a couple of times because there was an accommodation spasm happening, and we thankfully patient was actually metrope. Could have otherwise gone ahead and gotten a smile surgery done. Good logic prevailed at that point in time. Hyperopes, I would cycloplease. Hyperopes, I tend to delay as much as possible because they're not good candidates. So until they are extremely motivated, I would probably cycloplease them once or twice to make sure they accept very well. Atropine, I think, is only for enemies because your patients are going to run away and they're not going to come back because they're going to be paralyzed for a week. So as of now, like both Ridhima and Sharon said, atropine I've never used in any of my pre-op workups ever.
Okay, so I have come across a discussion wherein they say that for myopes who present with esotropia or let's say esophoria, we can do the atropinization and check the refraction.
So that's the accommodation. That's the accommodation.
That's a completely different situation. So if you're suspecting, so in our evaluation, you have to have a basic assessment of their ocular movements, esotropia, phoria, anything like that. If you feel that they have any such, orthoptics related issues, obviously check their binocularity and, do whatever is required to assess that. So, but if they don't have anything like that, then there's no role for.
Any patient that's coming with ESO happening with a myopia is not a refractive candidate because, for sure it is a pathology.
They're going to have, they're going to have problems after. So the assessment of refraction, has to be as detailed as even if you had to give their glasses. So whether it needs tropicamide or cyclopentolate or any of the other measures to assess their refraction as accurately as possible, it would all still hold good. So
also, I would like to ask if while we are evaluating the patient, is the dry eye evaluation done? Do you all do the dry eye evaluation for all your refractive cases?
Yeah. So dry evaluation, at least a basic, Schirmer's, and when you look at the slit lamp, have a quick look at the terminus height. That's basic. If you can do anything more detailed like a T-butt and all, it's fine. But what you're really worried about would be a low Schirmer's. So this thing, and of course you're looking at their lids or any other cause for an evaporative dry eye. But quick, at least a cursory examination, I think is mandatory.
So any cutoff, ma'am, because we generally do the Schirmer's in the clinic. So is there any cutoff that you all follow for the dry eye evaluation before, mostly for the LASIK? I feel, I personally don't, but for the LASIK patients, I would definitely have a cutoff not less than 10. So I would want to know your experience as for the dry eye evaluation for these cases. And if it is less, how long do you wait before doing the LASIK procedure again?
True. So definitely if a patient's Schirmer's is low, so then if you, you rightly said a cutoff of 10. So if it is somewhere around 8 or 10, then you could give them a course of treatment, whether it's your lubricating drops or, cyclosporin or whatever you think is adequate for that patient, and assess them in a few months. But if it's much lower, say a patient of a Sherman's of 5, then you would, I would, at least in my hand, I would say that's not a fit candidate for undergoing a LASIK or laser-based procedure, because you know that they could potentially have problems in future, and they would need evaluation as to why they have such a low Sherman's. Of course, many people, count it as a relative contraindication, but that could be a personal choice. But severe dry eye is definitely contraindicated. Around 10-ish, you could wait, see how they do, and then give them enough counseling, explain to them what is the potential issues, that it could get worse. They could be on long-term treatment for it, and then assess how they respond to that. So
I think two important points for all junior doctors. One is to, if at all, when you're setting up your practices or when you're in clinics doing your residency, it's very important to sit on the machine, because sometimes the optometrists are the best people in heavy clinics to tell you whether the patient has a poor tear film, because the Mayas keep breaking on topographies and all these corneal diagnostics. I would personally, in my clinic, I have a manual keratometer plugged in right next to my slit lamp, and I do all manual case, even for LASIK patients myself, because it gives me a plethora of knowledge, particularly on the tear film optics. Because, if your Mayas are breaking up and you have them to blink every now and then, it gives you much more than, of a practical experience. So to look at the surface more optically, manual keratometer is a simple thing to do. Very underrated these days, but it has always helped me in diagnosing subtle dry eyes quickly.
yeah.
For the benefit of our audience, can any of the panelists just evaluate what are the criteria for LASIK and what are the criteria for the patients undergoing ICL? Just to have the basic of it.
Criteria on the topography, or?
Yeah, based on the first is the age, then the refractive error. Like what are the basic points because we have the whole general ophthalmologist also. So for their benefit, if anyone could evaluate what are the criteria which actually makes it suitable for LASIK, or maybe we can actually have it the other way. What are the criteria, the red flags where we will not proceed with LASIK?
Okay, so any candidate who comes for refractive surgery, the first, as you started off with, the age of the patient should be preferably 21 years of age. At least 18, but we prefer to wait till the patient is 21 years. The younger the patient, the more is the risk for that patient to develop ectasia. So you wait for the patient to be at least 21 years. The second is stable refraction. So you need to ensure that the refraction hasn't changed by more than half a diopter over the last year. Even if the patient is 21 years and you feel like the refraction has jumped, you need to wait again to ensure that it is stable. The third criterion is looking for comorbidities. You need to look for systemic illnesses like any autoimmune conditions or uncontrolled diabetes, things that may interfere with the wound healing process. If the patient has a tendency for keloid formation, so you need to ask for history that the patient is not pregnant, which would then be a contraindication for the procedure. Look for local comorbidities, like Sharon had mentioned about the lid surface, blepharitis. So any comorbid ocular condition like uveitis, glaucoma. So these have to be assessed to ensure that the patient is a good candidate for the refractive procedure. After that comes the corneal thickness. The corneal thickness needs to be at least 480 microns for us to be able to proceed with any kind of refractive procedure. And after that, you would be seeing that usually per diopter of treatment that we need to do for myopia, about 13 microns gets ablated. So you need to match the refractive error that we are trying to treat, and as we had discussed, leave behind at least 300 microns of residual stromal bed after a LASIK. Usually my cutoff for SMILE would be about 280 microns, or not less than that. Other than the pachymetry, the next important value is the keratometry value. So the estimated post-operative keratometry value should not ideally be flatter than 35 diopters after a myopic treatment or steeper than 50 diopters. after a hyperopic treatment. So what would that mean? Like the cases that were presented today, the keratometry values were about 45, 48. And even if we were to correct a 8 diopter of myopia, you would still be left with, it's not going to get flatter than 35. 45 minus 7 would still leave you like with a decent keratometry. But if the patient were a hyperopic patient and plus 6 diopter of hyperopia, if we were to treat with a 45 diopter pre-op K, that would not be a good candidate to proceed with a hyperopic LASIK then. So the K needs to be looked at. And the most important factor on the topography is the curvature pattern. You want to make sure that it's not irregular. There's no inferior steepening on the curvature map on your pentacam. Other than the elevation maps, like we saw the Bellin-Ambrosio scale, that the final D value. So all of these values would also be important in making sure that the patient is a good candidate to proceed with LASIK. Other than the topography values, I think the most important is the personality of the patient, his reasons for getting the procedure done, what is his motivation for the procedure, and what are his expectations out of the procedure. I think a lot of chair time is required to assess a patient before proceeding with refractive surgery. I think that's the most important out of all of these earlier 6, I think, parameters that we discussed. And in a phakic IOL, other than these, the anterior chamber depth, it has to be, nowadays we say 3 millimeters at least, if not 2.8 millimeters. You need to assess the anterior chamber depth, even clinically, and make sure that the angles are open, the iris configuration is normal. Look for any other ocular comorbidities before proceeding for ICL. The pupil size is also important, the mesopic pupil size, before planning any refractive procedure. So I think this is the important points that I could think of offhand. You're free to add some more.
Right. This was excellently covered.
I think one very, I mean, the list was near perfect, Ridhima. Yeah, so just one extra thing is, if the patient is a contact lens user, then depending on what kind of contact lenses they're using, whether the soft lens or the semi-soft RGBs, any of those. So we have to remember to tell them to avoid the contact lens for a short period of time. Now that is easier said than done, especially for the high myopes, because they hate giving up their lenses for even a day. So sometimes what I have done is ask them to come in, like stop for one eye for a few days, come in, get the scan, stop for the other eye, and come, because they feel that they are totally incapacitated if we tell them to remove their lenses for say a week without it. So you have to get around to all that, but it's very important. It's also important, especially for someone who's just starting out, to be able to identify contact lens warpage on a topography. Because sometimes you may think that that's some sort of an irregular cornea or an ectasia. So it has a very irregular pattern, but it won't fall into any of our classic pictures of, inferior superior asymmetry or elevation patterns, thinning. So if you see something very irregular, you have a doubt, patient is a contact lens user, it makes sense to ask them to, avoid the lens and repeat the scan before either ruling in or ruling out a procedure. So that's also very important to remember. Other than that, yeah, I think she covered everything. So
I'll just add 2 points because I need to add something to this. So I think we'll go back to digress again because of junior doctors. There are 2 things to understand. For me, the maximum cancellations for LASIK happen because of retinal problems. More than my residual stromal bed and the corneal pachymetry are retinal problems. And I've had the good fortune of training with very good hands in Shankar Nethralaya or indentation indirect ophthalmoscopy. But I still, for 100% of my LASIK patients, I take a retina referral. Because God forbid something goes wrong, I should not be the one to be blamed because somebody has parallelly reviewed and given a green check. So always very important to rule out any retinal pathologies by a good retina colleague. There's no retina doctor in my hospital, so the patient has to go to another hospital, pay another consultation, get it checked up, which adds more weight to the consultation and makes the patient very comfortable. That's number 1. Second, like Ridhima brought about, it's the patient personality, because a lot of these myopes have very unrealistic expectations, and people with unrealistic expectations are not good candidates because the problem is in their eye, it's their vision, and it's their suboptimal visual potential. They're not going to see 6/5, unlike a low myope, so they're going to be limited to 6/9, 6/6 parts, and they have to understand that we are only just removing glasses and making them compatible for their vision, for their retina. We're not putting an extra vision in their eye because we can't do that. And sometimes it's very important to understand that people who come in their 1920s alone or with friends to get surgery done, I always tell them to bring some family members, preferably parents. Otherwise, I will not touch their eyes, because later the family member is going to come and stand on your head as to why did you operate this child without taking permission. So apart from all scientific problems, practical problems, so these three are, I think, very important and best learned by seniors and learning with experience.
Right. So this was excellently covered by all the panelists. Just for the interest of our viewers, I would just like to mention that the anterior chamber depth that is being measured, we should make a note that it is from the endothelium. What we get on the IOL master is not from the endothelium. So we just need to subtract the patty, and the cutoff is again 3 mm or 2.8 nowadays. Second thing, the most important, LASIK part has been excellently covered by Ridhima ma'am. She's given us all the parameters. For the ICL, white to white is a very important parameter. As Gunjan said that they did the white to white from ASOCT and IOL master. I personally do it with a manual caliper. So I would want the opinion of our panelists as well as to what is the way that you all confirm the white to white.
So usually I would suggest taking as many, I mean, if I have access to the pentacam and the optical biometry and a caliper, I would use all the methods possible and then go with my instinct. So I think I would, I rely more on the manual caliper measurement at the end of it, but I would take as many measurements as are available to me at that point of time, I think. Yeah.
I would agree on the same.
Yeah, I agree. Yeah, you do at least find at least two things you can do, and the manual caliper is pretty easy to do, and you can compare it to at least your topo, and if you're doing an ICL, you'll have an optical biometer. So take as many as you can.
I'd like to ask a question here to both Ridhima and Sharon. How do you do a manual caliper? Because I have my own way of doing it in the OR, but I want to know because digital calipers are too big and it scares the patient away. So how do you do it?
But I do with the digital only.
So I'm going to be very honest.
Make the patient look ahead.
I take the old vernier calipers and I take it. I do it I do not take the patient to the OR. I do it on the slit. I mean, in my OPD, I use the vernier calipers and mark it on a paper, and I measure that reading.
So that
I think used the digital caliper, and I think it's.
No, so I've had patients who got scared with their big digital caliper. So like Ridhima said,
it's a little sharp as well, huh?
Yeah, it's sharp. It's sharp. It can sometimes abrade the cornea.
So yes. If they move suddenly, that you have to be a little careful on that.
So I tell the patients that I'm going to give you a mock tour of the OR, and this is how the procedure is going to be. And I run them in the OR, and I put them on the table, put a Lieberman speculum so it's not tight. And I use the vernier, the old calipers, the old cataract ones. And again, like Ridhima said, I punch them on a paper, and then I use the digital calipers to measure those two dots. So rather than putting the big thing, because I can never handle the big one, and I'm impressed with ones who can measure on slit lamp using the big caliper, because it's quite a task.
No, I think I also follow the same. What it has been agreed, we all take them to the OR saying that we are giving them a tour so that they are also accustomed to it. And manual caliper is my personal choice. I have seen a difference of almost 1 mm in a manual caliper as well as an IOL master. Does anybody of you have similar experience?
Yeah.
And
yeah.
So the optical biometer will typically overestimate. It may be slightly different with the different machines if you have a Lenstar or IOL master, the NIDEC one. But usually another thing that I do is I never just order the lens. I would always discuss it with the company representative. When I submit it, I will ask him to go through the sizing. Sometimes I would have opted for, the smallest size ICL, suppose my white to white measurement was 11 millimeters and it's recommended a 12.1 millimeter size. I would usually discuss it, or if it's the highest size, it's a 13.7 millimeter ICL recommended by the software. I would usually sound it out with the company, and once if they suggest something, I would still discuss it with them and then go ahead and order. Or if I'm in doubt, I would probably order lens just for the first eye that I think is safer to proceed with, see the vault, and then order for the other eye if there's a discrepancy in the two.
Right. So we have some more questions from the audience. So Dr. Prashant wants to ask, are there any home monitoring tools for dry eye? So maybe Dr. Sharon, you can take this question since NN does a lot of dry eye research work.
Yeah, but I don't really know of any home monitoring tools for dry eye other than, I mean, what else can you self-administer other than a questionnaire probably? So, to check your symptomatology, but I don't know of any other home monitoring tools. I'd be happy if anyone else has any experience of it.
I think it's a good potential place to work on, because I don't think there's anything, to my knowledge, also at the current situation, other than trying to keep your eyes open for the longest time possible and not blink, probably.
Okay, so one more question we have from Dr. Bhattad. In case of mentally retarded myopic patient, what will you advise since they don't use spectacles most of the times? So it's probably a mentally challenged patient who has a refractive error. So will you advise any refractive procedure to this patient?
My first choice would be to do nothing. If
Do
it's a low
nothing,
myope,
yeah.
it's always good for the patient, because anyways, the surrounding area is the important visual field for them. So I don't want to make them emmetropic and disturb them. If the patient can give a visual acuity and is a low grade, like a spectrum of Downs or maybe something like that, maybe if it's more towards normality. But for anybody with anything subnormal, because there's chances of injuring the eye, rubbing a flap away, I wouldn't recommend any procedure.
Yeah.
True. I recently
Also,
had.
to get them to cooperate it would be difficult.
Yeah, for the
You have to
procedure
unnecessarily sedate them or give anesthesia. It's
Absolutely.
not worth it. I mean, if it's a condition where we are saving the eye for some reason, we have a high drops and things like that, then it's a totally different ballgame. This is for just getting rid of spectacles. I wouldn't do anything.
Dr. Ridhima, you were going to mention some.
Yes, I recently did have a patient. She had a high myopia. She was about 24 years old, and she had a myopia of about -8 and -9. And her parents were extremely motivated to get refractive procedure done for her. She was not exactly, I mean, it seemed difficult for her. I mean, it didn't seem like she would cooperate for a LASIK or a SMILE procedure. So I gave the option of, sedating her and doing a phakic IOL implant, but I did not really push them much. I said it's best to probably see if she can, continue with spectacles. And if not, then we would consider a phakic IOL procedure, because I don't think she would cooperate with a laser refractive procedure. But I haven't yet done it for her. So still waiting.
This just gets me to one question. If any of you remember, there was a paper in AIOC in Coimbatore. Would you do a LASIK in a young patient less than 18 years to help him in amblyopia management? This was presented in AIOC Coimbatore. So this was a discussion we actually had in one of the ICs.
I would probably, because we do a lot of pediatric cataracts in our center, and we are using pediatric contact lenses under Dr. Vaishali. I would rather put a contact lens in an eye, rather than touch and change the shape forever. And contact lenses would work very well. If the patient is cooperative, one could even try ortho-K, which is really coming up again, back into fashion. But rather than doing a permanent lens-based procedure or a corneal procedure, which I don't think is the right thing to do, because there's a long way to go for the patient.
I agree.
There have been papers on it, some time back, quite a few years back, actually, even internationally, but hasn't really gained that much of popularity for exactly the same reasons which have been mentioned, that you don't want to permanently change it. The eye is still, potentially growing. So.
Right. Also, if this patient, we were discussing both the cases, if they had nystagmus, what would be the treatment option? Would we still go ahead with LASIK in these cases?
I have done relax SMILE procedures in nystagmus, and they've been pretty, I mean, it's been possible to do it. And I think even
how do we ask them to fixate that? I mean, basically, we need to tell the audience how do we ask them to fixate?
So in a femtosecond laser, the laser is going to hold the eye while doing the laser. So at that point, so it's pretty easy. In fact, the issue can arise when you're dissecting. That's the time actually when the femtosecond laser is delivering or making the flap or creating the lenticule in SMILE. The nystagmus is not going to play a role because the suction. But while dissecting, it can be a little challenging, but it's been possible to do it, especially if you are holding a fixation device like a forceps and trying to dissect, it can be done. And even an ICL can also definitely be done. Yeah.
Yeah.
Even when you're firing a laser,
the challenge is when the excimer laser is being fired. That is
Yeah.
where the challenge will be. So you have to hold it, and if too much a problem, you may have to even put off the iris recognition sometimes because it will be moving. But otherwise, it's.
I think Nandini, in interest of time, we may be taking a couple of more questions, and then we'll have to close the session.
Yes.
So Dr. Karan wants to know: would you give a peripulvar block in such cases of nystagmus?
For ICL, maybe. For LASIK, I would not recommend.
Refractive surgery needs the patient to fixate, right? Like we are centering the treatment on the visual axis. So it's essential that the patient has to be cooperative and look at the fixation light for any kind of laser to be centered and successful. So no, only for an ICL, I think a block can be considered.
I guess to summarize our talk, we have discussed the criteria for ICL and LASIK. Can any of the panelists please evaluate the criteria to diagnose post-LASIK ectasias, which is a very nightmare for any of the LASIK surgeons?
Right. So I think, again, in interest of time, I'll try and keep it short. The first thing, when you suspect a post-LASIK ectasia, the first thing is the patient coming back with some form of a refractive error back to your OPD after they have undergone any of the corneal-based refractive procedures. So that's when you think of either it could be a regression or an ectasia. If there is a significant enough, like a larger refractive error, both at 0.51 diopter of change, then you have to get the whatever corneal topography is available to you, preferably the one which was done before surgery. And what we need to remember is that, of course, a change in keratometry, the elevation criteria do not apply the similar way that they apply to our normal, the pre-operative maps, because a lot would have changed since the time of surgery. Obviously, we have flattened the cornea or steepened, depending on whether you've done a myopic or hyperopic correction. And usually post a surgery, immediately after surgery, would not have done any topography. So you don't have a baseline pretty much. So the only thing that you can look at is a change from what you would expect to be the myopic ablation. So you have a donut-shaped ablation, usually the central flattening with the peripheral steepening for a myopic change. So if you have a difference from that, suppose you have a central island which is coming up, a central steepening which is coming up in that myopic flattened area, then that would be something which is suspicious. Elevations cannot be counted on, but of course, if you see them, you would still give them some value. And you must remember that most of our topographers are not good. If there is a post-PRK haze, then you don't get an accurate change. So you're basically looking for some central steepening and a little bit of elevation change, and that would be your indicators that this patient may be going into an ectasia. And then just wait. If you're waiting on that patient, then look for any change progressively. So otherwise, there's not much else. Anyone wants to add anything?
So I think we are towards the end of our discussion. Any of the panelists would like to comment or summarize anything?
I think it was a great session, very well coordinated by Dr. Aarti, Dr. Nandini, and Dr. Gunjan, who presented the case, and excellent discussion. I'm sure it was useful for everyone around, irrespective of what stage in their clinical practice they are. So thank you very much for having us here.
I am sure the audience might be having a lot of questions. So if the panelists are okay, can we allow them to post their questions and you all can answer it, and we can have it put in the YouTube, because we have a YouTube live session. So maybe later on also, because we have a time limit of an hour. So we'll have to wrap up today. But after the session, I'm sure that we'll be getting a lot of other questions again. So is that okay with the panelists?
Absolutely.
Yes.
Yes, sure.
Because I'm sure keratometry itself is going to be a long talk and we cannot complete it in an hour. Maybe we'll have to have a separate session on that. So I think for today, we really had a good discussion. And I'm sure our viewers would at least have got the basic idea of the workup for the basic and the refractive surgeries, and they must be more comfortable now to go ahead with either of them.
Yeah, so let me thanks our audience for making the discussion so interesting by their interesting questions. Thank you all the panelists. Thank you Gunjan. Thank you Dr. Nandini for moderating the session. And I think we'll see you in next session. So here we are ending the season 1 of Surfing the Anterior segment, and next month we'll have something different. So let's wait to see what is coming next. So good night. See you all for the next session.
Thank you.
Good
Thanks a
night.
lot.
Good night. Thank you.
Thank you.
Thank you. Thank you, everyone.